بسم الله الرحمن الرحيم. صباح الخير طلاب كلية الطب مرحلة الخامسة، رمضان مبارك. Our lecture today about acute leukemia. It will be in two parts. We start with the definition of acute leukemia. Acute leukemia is a clonal malignant proliferation of hematopoietic progenital cells characterized by abnormal or impaired differentiation. Incidence about 1.8 per 100,000 population. Specific non-randomized chromosomal translocation of a specific class of cellular gene, transcription factor, and cell signaling molecules with tyrosine kinase activity. So result in production of fusion oncoprotein. So there is chromosomal abnormalities. There is a new protein which is called oncoprotein. Oncoprotein is malignancy. This enhances abnormal differentiation of cells, mainly white BC. So no evidence of failure to produce or response to cytokines. All these malignant cells have non-programmed differentiation, cannot be controlled by normal programmed enzymes and signals. Acute leukemia classification, we have two types, acute and chronic. Chronic myeloid leukemia, chronic lymphocytic leukemia, we talked about in previous lectures. Our topics is about acute leukemia, differentiated two types, acute lymphoblastic leukemia, T or B cell in origin, and acute myeloid leukemia. How we differentiate between the two, how we differentiate between AML and myeloproliferative disorder and myelodysplastic syndrome. Proliferation, more in myeloproliferative disorder. Differentiation is blocked in AML. Cell death, more in myelodysplastic syndrome. Phenotype, leukocytosis, thrombosis, ineffective hemopoiesis, cytopenia, accumulation of blast in AML. This is the characteristic of AML, MDS, and myeloproliferative disorder. FAB, French, American, British classification of acute leukemia. Acute non-lymphoblastic leukemia, which is called M0, to account for 5 to 10%, less than 3% blast, stand for myeloperoxidase positive, and PAS and non-specific enolase stain, less than 3% staining. Myeloid antigen, immunohistochemistry is positive for cluster disintegration, 13, 33, and 11B are positive. So more specific test for AML, M0 is antigen test, or what we call CD marker test. This account about 5 to 10%. M1 myeloblast without maturation, more than 90% of cells are myeloblast, 3% blast stain with myeloperoxidase enzymes, and positive or frequency seen, positive A frequency seen, chromosomal 8 additional chromatin material. M2 AML with maturation 30 to 40%, so it's common. 30 to 90 are myeloblast, about 15% translocation between chromosome 8 and 21. M3, we concentrate on M3. Please concentrate on M3. Why? This account for 10 to 15%. Marrow cell, hypergranular promyelocytes, ORODS body available. This is ORODS body available. Classical hypergranular, 80% leukopenic. Variant hypogranular leukocytosis. Granules contain procoagulant, thromboblastine-like. So this patient, M3, presented with disseminated intravascular coagulation-like picture. And we should know that translocation between 15 and 17 chromosome is diagnostic. Why we concentrate on this type of leukemia? Because it is a curable type of leukemia. Curable type of leukemia. What about M4? Acute myelomonoblastic, 10 to 15%, characteristic by CNS involvement, monocytes, promyelocyte, 20 to 80%, M4 with eosinophilia, means eosinophil more than 5%, peripheral blood. Deletion or inversion, Q part of the chromosome 16, marrow eosinophil about 35%. So M4 characteristic by CNS involvement, which is bad prognosis actually, and by eosinophil. What about M5? M5 characteristic M5 is gum hyperplasia, and this can be seen in vitamin C deficiency, patient taking phenytoin. But whenever the patient presented with fever, abnormal blood film, this is most likely M5. M5A, acute monoblastic, 10 to 15. M5B with differentiation less than 5%. Often associated with gum and skin infiltration. Skin infiltration like nodules or let us say the skin elevation or erythematous rash, which is called leukemia cutis. Actually, there is no picture for this. So skin infiltration, gum infiltration, this is M5. M6, it is related to red blood cells. So it is called erythroleukemic, digoglimo, less than 5%, 50% or more of all nucleated marrow cells are erythroid precursor. 30% or more of the remaining non-erythroid cells are myeloblast. If it is less than 30%, then myelodysplasia. So how you differentiate between M6 and MDS? Blast cell and the bone marrow. It is more than 30. This is M6. It is less than 30. It is myelodysplastic syndrome. M7, affect platelet. So abnormal proliferation of platelet, less than 5%, associated usually with fibrosis, diffuse marrow fibrosis. Confirm origin of platelet by peroxidase enzyme, electron microscopy, or MAP, monoclonal antibody to von Willebrand factor or glycoprotein. This is very rare type of leukemia. So Fab classification, M0, M1 up to M7. What about ALL, acute lymphoblastic leukemia? Fab classification, L1 85%, L2 14%, L3 Burkitt lymphoma 1% in pediatric age group. L1, L2, L3. L1 uniform, small size, high nucleochromatin ratio, regular nuclear margin, inconspicuous nuclei. L2 heterogeneous, large and small cell, variable cytoplasm nuclear margin, prominent nuclei. L3 large cells, deeply basophilic and vacuolated cytoplasm, prominent nuclei. Acute leukemia, epidemiological factor. Is there hereditary factor for acute leukemia? Yes. Fanconi's anemia, Down syndrome, ataxia, telangiectasia, all these hereditary diseases, and those patients with these hereditary diseases having tendency to develop acute leukemia. What about radiation? Yes, radiation, chemicals, and drugs also predispose for acute leukemia. يعني الناس اللي تشتغل بمعامل البتروكيماويات، الناس اللي تشتغل في المفاعلات النووية، وحتى الناس اللي يشتغلون في مكانات القسطرة اللي بيها radiation exposure أو مكانات المعالج الخطي لعلاج الأورام linear accelerator، هذول كلهم liable for getting acute leukemia. الفيروس اللي related to leukemia, one known virus هو human T lymphocyte virus, and the most important one is Epstein-Barr virus. يعني نعرف ان الإبستان-بار فيروس هو أكثر فيروس له علاقة بالليمفوما. Molecular evidence acute leukemia. إذا نحكي عن molecular evidence, oncogene. شنو هي الoncogenes؟ هي genes that code for protein involved in cell proliferation or differentiation. Tumor suppressor genes, change within oncogene or suppressor genes are necessary to cause malignant transformation. يعني differentiation of cells controlled by, as I mentioned, by signals and gene processing. Whenever there is disruption for this control, as its name, tumor suppressor gene. Whenever there is malfunctioning of this gene, so the cells having tendency to malignant transformation. Cancer of the blood affecting the white blood cells known as lymphocytes. Now we are talking about acute lymphoblastic leukemia. Common as the age 2 to 10, peak 3 to 4 years, incidence decrease with age, and secondary rise after the age of 40. So this disease of pediatric age group. In children, most common type of leukemia, about 85%, is acute lymphoblastic leukemia. Acute lymphoblastic leukemia, how they present: bone pain, extramedullary expansion, arthritis, lymphadenopathy, mainly cervical, hepatocellular mediastinal mass, testicular swelling, and even meningeal syndrome, what we call leptomeningeal involvement, which is bad prognosis. What about AML? Arise from malignant transformation of myeloid precursor, rare in childhood, 10 to 15%. Incidence increase with age, so AML is a disease of middle age and adolescent, 80% in adult, most frequent leukemia in neonates. They said it is common in two extremes of age, very young age and elderly. This is AML. How they manifest? As I mentioned before, gum hypertrophy M5, hepatocellular M2, skin deposit M5, lymphadenopathy M1, M2, renal damage M6, and disseminated intravascular coagulation, promyelocytes M3. How you investigate for those patients? Investigation: full blood count, reduce hemoglobin, white BC، وهنا الوايت BC مهمة. طبعا leukocytosis associated with activity of the disease and considered as bad prognosis. كل ما تكون white BC أكثر من 50,000 بعض الأحيان 100,000 معناته الديزيز more aggressive. thrombocytopenia، platelet تقل على حساب ال over production of the white blood cells. ممكن يجي البيشنت لوكوبينيا، هاي يسموها الوكيميك لوكيميا او سب لوكيميك لوكيميا، يعني يلقى فقط بلاد سيل بالبون مارو وليس بالبرفرال بلاد. هاي صورة للأكيوت ليمفوبلاستيك لوكيميا. lymphocyte abnormal proliferation, increased number of lymphocytes. This is acute myeloid leukemia. This is RBC and this is myeloblast, premature white BC. ALL, how we differentiate it by blood film: blast size small, cytoplasm scanty, chromatin dense, nucleoli indistinct, all rods never present in ALL. What about AML? AML تكون large عكسها moderate, fine chromatin prominent, and 50% they have all rods body, especially M3. حتى نكمل الدايجنوزز مال leukemia, we should have bone marrow aspirate and biopsy to confirm acute leukemia and when the blast cell is more than 30%. معناته اكو blast cell بالبون marrow. Yes, معناتها نسبتها يعني less than 5 or 10%. But if it is more than 30%, it means acute leukemia is there. Usually the bone marrow is hyper، مثل ما تشوفون كلها cells hypercellular. Cytoplasmic أو cytochemical staining, peroxidase, negative in ALL, positive in AML. Negative in ALL, positive in AML. Periodic acid shift, positive ALL, block, and negative in AML. Acid phosphatase, focal positive, acid phosphatase positive. This is specific for T-type acute lymphoblastic leukemia. So, cytochemistry reaction in a blast: myeloperoxidase positive in AML, negative ALL. Sudan blood positive in AML, negative in ALL. Non-specific esterase M4, M5, periodic acid shift, mainly M6, maybe positive in 40–60% of cases. Acid phosphatase positive in AML and also in T-type ALL. We stop here and continue later.